if I could give my thanks also to Julia and the BTF team for organising this webinar today. So quite a lot to get through in the next 15 minutes, but I will try and very much keep to time today. So thank you, Julia. Next slide. Or in fact, can I drive this? No, I can't. So what I'm going to talk about is, as Christian has said, an overview. And I'll start with just talking generally about thyroid nodules. We'll talk about the various treatment options for benign disease, the availability of ablation currently in the UK. And I'll touch upon what referral and assessment pathways might look like, very briefly about the procedure itself. And we'll talk about the advantages and disadvantages of ablation. And I've also been asked to talk a little bit about the future. So I've got a couple of points to make about what might be coming up ahead in the future with ablation. Thank you, Julia. So as I'm sure you're aware, thyroid nodules are very common. Thank you. And in fact, if you could just run through that slide. That's lovely. And just keep on going, Julia, till you get to the end of that. Thank you. That's perfect. So thyroid nodules are very common, over 50%, sometimes 70% in the literature in patients within an older age group. And remarkably, about, well, over 6% of women, 1.5% of men will have a detectable nodule. So that's a nodule that can be felt or may be seen in the mirror as well. And remarkably, we're picking up a lot of thyroid nodules incidentally on imaging done for other reasons. So anywhere between 50 to 30% of imaging will also detect a thyroid nodule, which is unrelated to why they've had the scan. And a small proportion of patients will also have what's called an active nodule. So a small nodule that's either hot or toxic, which is causing, which may or may not cause symptoms, but is producing thyroid hormone and warrants treatment because of the longer term effects on the heart and bone density as well. But reassuringly, 95% of nodules are benign. Thank you. Now, what are the treatment options for benign disease? Well, first of all, you could leave a nodule alone and just manage it conservatively. If it were to become a problem, then we could revisit the issue. In the context of benign disease, radioactive iodine is used for overactive thyroid problems or focal hot nodules, but the mainstay of treatment is surgery, and that can be a partial or a total thyroidectomy. Thank you. Now, this is an interesting paper, and it gives us an idea of how much surgery we're performing. So over the past 6 years, over a 6-year period, we've performed just within the NHS, almost 70,000 elective thyroid surgeries. And the vast majority of those are for benign disease. So the interesting point here is that perhaps a proportion of these patients could actually go on and have ablation rather than surgery. Thank you. Now, surgery is a really good operation. It gets rid of the problem. It doesn't tend to recur, and it has a very low complication rate. But in terms of my experience, for benign disease, patients particularly want to avoid surgery if they can, and they want to have a thyroid sparing treatment if possible. Thank you. And the next slide. So that's really where thyroid ablation fits in. And RFA was recommended by NICE in 2016, microwave ablation in 2022. And in principle, they are very similar in what they're doing. So essentially, you insert a needle into a nodule, either by radiofrequency or microwave energy, you generate heat around that needle. And cells are very sensitive to heat. So even temperatures of 60 degrees and above will denature or inactivate the proteins within the cell dies, and therefore the nodule shrinks. Thank you. Now, I know that Tim will talk a little bit about ethanol ablation, but that's another technique which is recommended for predominantly cystic nodules, and it's a cheaper and very effective treatment as well. So if we were having this conversation even 18 months, 2 years ago, there may have been only 3 or 4 centres that were up and running and performing ablation. And now we have a really good spread across the UK of both RFA and microwave ablation, and a number of centres that are almost ready to start as well. And I'm sure if we came back and had a conversation again in a couple of years' time, there'd be even more centres well established with good experience. So in terms of referrals, we predictably get most of our referrals from our ENT colleagues, some from our endocrinologists. We also take a fair few out-of-area referrals, either from doctors, and we get some direct inquiries from patients. And if we do get direct inquiries, all we ask for is a letter of referral from their doctor, and then that allows us to transfer their imaging and make an assessment. Now, I don't have any experience with individual funding requests, but some centres, when they're accepting out-of-area patients, I know do ask their GP, I think, to request an IFR. This goes to an independent panel that makes the decision on funding. We don't tend to do that in Reading. We essentially are reimbursed for the work that we do, so we haven't found it necessary to go via the IFR route. Now, in terms of pre-assessment, for out-of-area patients, I normally start with a telephone consultation, but otherwise everyone will have an ultrasound consultation. We assess their symptoms. So what we're really looking for are perhaps a couple of dominant nodules that are causing the symptoms, and we want to correlate those symptoms to the nodule and be really confident that we're treating what we think is the issue. We'll always look at the size. Size is critical where ablation is concerned. The larger the nodule, the more challenging the ablation. And we're looking at the grade of the nodule. So that means, does it look benign? And we also do 1 or 2 confirmatory fine needle aspirations. So these are very simple local anaesthetic tests, which allow us to confirm a benign nature. And the only blood test that we do routinely at the moment is a thyroid function test. Thank you. Now, RFA, or indeed microwave ablation, is performed as a day case under ultrasound guidance. We perform ours in an ultrasound room. And predominantly, it's a local anaesthetic technique. We're in fact moving away from giving conscious sedation, because ideally you want the patient alert and orientated. If you're irritating a nerve, if you're causing a voice change, you're much more likely to pick that up by just providing local anaesthetic. Thank you. And essentially, we keep patients for 2 hours after the procedure. By and large, patients will go home at that point, and then we will follow them up in the longer term. So we see them initially at 3 months, and then we will follow them up to 5 years as well. And there's a recommendation, again, in the literature, in guidelines, for this longer term follow-up for ablation. Thank you. And the next slide. So in terms of advantage, I think it's pretty clear. It's minimally invasive, therefore you recover slightly quicker and you can do the procedure again if required. It is truly thyroid sparing. So all things being equal, if it's a healthy thyroid gland, otherwise, there's about a 1% risk of causing hypothyroidism or underactive thyroid. And it's also a single session treatment, which is effective. So when we first started, we thought we were going to be doing double ablations in a fairly significant proportion of patients, but actually the need for that is quite low. And it also has a low complication rate as well. But there are disadvantages. And the first is that there is a size limitation. So the larger the nodule, the more challenging. We may get poor shrinkage, and there may be a need for repeat treatment. We need to remember that it's shrinkage, not removal. So in other words, we treat within the confines of a nodule. So we don't cause damage to surrounding structures. And that means that we don't disappear the nodule. So if a patient were particularly concerned that even though it looks benign, I'm still worried that there might be a cancer in there, well, actually, perhaps surgery rather than ablation is the way forward. And there's also a risk of regrowth because we're not removing the entire nodule. So no histology, what do I mean by that? Well, essentially, when a surgeon removes a nodule, we get to see the entire specimen that can be examined under a microscope. And about 5 to 15% of benign nodules that are removed, we find little cancers within them. Now, we don't know how clinically significant, how important those cancers are, but nevertheless, that's something that people should be aware of when they're considering ablation and balancing it against surgery as well. And I guess this could be a good or a bad thing, but there is a need for longer term follow-up. Certainly there's a cost element attached to that, but some patients may like the idea of a longer term follow-up just to keep an eye on how things are progressing. Thank you. Okay, so on the home straight. So just a couple of points in terms of future direction. So at the moment, we treat ablation and we treat moderately large nodules, but we do struggle with the larger nodules, perhaps the ones that are dipping down into the chest. But we do treat those. There's no necessarily specified upper limit at which you would stop treatment. But we really should cross the line at diffuse multinodular goiters. This is really difficult to treat, where you have multiple nodules on both sides of the gland, and that's really a surgical case. And the question is there an option between ablation but before surgery that is minimally invasive? And the one option is thyroid artery embolization. So thank you, Julia. And the next slide. So thyroid artery embolization, and you may as well just run through this slide, is for larger nodules or patients with Graves' disease. So larger nodules, I mean those that we might find challenging with ablation, but patients also want to avoid surgery. And the challenge with embolization at the moment, it is that the literature is not well developed. So it's being performed in limited numbers in other countries, but these are small series, and we don't have really good quality data yet. So it's performed through access in the groin or the wrist. And what we're achieving is an occlusion of the thyroid artery, so one or more thyroid arteries, and we're inserting or we're injecting an embolic agent to try and reduce the blood supply and shrink down the nodule. So we're quite excited in Reading. We're starting the target trial in a couple of weeks' time, we hope. And this is a small pilot study, and we're recruiting 10 patients. And a pilot study is a preliminary evaluation. So really, this is a small study to inform what we hope will be a larger study in the future, maybe a multi-center trial. And we'll also get a little idea about the safety, the degree of shrinkage we achieve, and also the quality of life impact. Thank you. So this is my second to last slide. So we know that there is an indication to treat benign nodules with symptoms or cosmetic issues, and even small hot nodules. But I think the next step in terms of ablation could be the treatment of very small cancers. And just one more slide to go, Julia. So essentially, the incidence of cancer is increasing. And the most common type of cancer is a relatively indolent cancer. So in other words, slow growing, unlikely to spread. And most of these cancers are very small. And you could leave these cancers alone with very good outcomes. But some patients do have surgery as well, and therefore ablation might be an option. Now, just very briefly, this is a meta-analysis. So it's a combination of several studies. So in this case, 20 studies, 6,000 patients. And they found by treating these really small cancers, they achieved really good nodule disappearance rates and nodule shrinkage rates. So it could be an option that's introduced in the future for really small cancers. So I've almost certainly overrun after the delays as well, but just really in summary, ablation is now being used as a first-line treatment in selected patients for benign thyroid nodules. So thank you, and my apologies for the technical issues, and thanks, Julia.
Thank you, Farhan. That was very enlightening. We'll leave the questions till after. So next up is Tim Youssef. It gives me great pleasure to introduce him. Tim is also an interventional radiologist who works at the Princess Royal University Hospital, and he's going to talk to us about ethanol and microwave ablation as alternative non-surgical treatment options. Thanks, Tim.
Okay, I'll just share my slides. So thank you for the kind introduction. I hope you can see that. As you mentioned, I'm Tim Youssef. I'm a consultant radiologist. I work at King's and the Princess Royal Hospital in Bromley. And I'll follow on from what Farhan said. There'll be a bit more overlap because these topics are quite similar. So what I'll aim to do is give you a practical point of view about when they're used, what they're used for, what can potentially happen, and what you as a patient will feel. Because I think that's very, very important. And it's always a great honor to be asked to speak at places, but particularly so for a patient forum, because this is one of my passions, is engaging people to teach them more about what we can offer. So without further ado, let's talk about alcohol ablation. So Farhan mentioned that with thyroid nodules, they're extremely common and not necessarily always needing treatment, because as we said, up to 60% of the population have thyroid nodules of some description. But if they are cystic, if they're large, if they're solid, they can cause symptoms, particularly compression. They may be noticeable on the outside of the skin, and the presence of a nodule doesn't necessarily mean that it needs to be treated. However, some nodules do, and one particularly problematic type of nodule can be the cystic nodule. And by cystic, we simply mean fluid-filled, which is why my representation of a bubble is there. Now, cystic nodules may be entirely fluid, they may be partially fluid, but what we know is that often when we take the fluid out, they can reaccumulate. And they can reaccumulate not just a couple of months later, a couple of weeks later, they may be instantaneous. We have plenty of times all seen nodules which we've put a small needle in, taken the fluid out, and then within minutes before the patient has left the room, we've seen it reaccumulate. And it's disheartening for the patient, disheartening for ourselves, and we want to try and improve that. So alcohol is a very, very well-proven technique. It involves injecting alcohol, usually from the midline of the neck, going into one side or the other, after you've aspirated the cyst, so after you've taken the fluid out. And you usually use somewhere between 95 to 100% alcohol. And what that does, it scars the inner lining, because it's that inner lining of the cyst that makes the fluid. And if you can scar that down, then it means it won't produce any more fluid, and gradually it will just resorb and resorb. So usually you see an immediate effect, and it then shrinks down a bit further over time. And usually the follow-up is around 3 months afterwards to make sure. Every once in a while, it does require a retreatment, but it is a very quick and effective procedure. We use it in also other organs. So, for example, I use it in kidney cysts, I use it in ovarian cysts, in liver cysts, and it's shown to work quite well. Reassuringly, the recovery time of this is very short. So once you've taken out the fluid, injected, we keep an ice pack on the neck for maybe half an hour or so, just to make sure patients feel okay, and then they're free to go afterwards. Now, it doesn't work in solid nodules. It does rely on there being that contact with the inner linings. It's got to be a cystic nodule. I'm going to come on to speak about complications shortly afterwards, because I'm going to group them together as a category. So alcohol ablation is quite a straightforward one. The one that I'm much more involved in is microwave ablation, and as Farhan said, this was relatively recently introduced into the NICE guidance, and NICE, as our highest governing body for medical purposes, is a way of determining what's not only safe but effective. So the presence of a NICE guideline really reassures us that we are doing the right thing, and backing behind that is a real wealth of data. So particularly from the Far East, from Europe as well, there was already a great deal of data out there talking about what we call thermal ablation, because radio frequency, microwave, even laser are often grouped together in that term. Microwave ablation is a slightly different technology, and I won't go into the finer points of it, but safe to say it doesn't involve putting your head into any kitchen instruments. It's not quite the same as that type of microwave, even though that is a question I get a lot. It's instead flipping water molecules, and it causes that burn in the skin. And there is a bit of a distinction between the high energy microwaves and the low energy microwaves. And this is a nuance of the technique. And this is, I think, it places it into different brackets of the literature. And this is something that we're trying to develop at the moment. Now, microwave as a technique, much like radiofrequency ablation, is used elsewhere in the body, and it's used for mainly cancerous treatments elsewhere in the body. However, it's very different in the thyroid. In the thyroid, we're talking about something that's close to the skin, causing symptoms around a number of delicate structures. So we're simply looking for size reduction. So we're not aiming to, people who, and I appreciate some people on the call may have spoken to me before, we're not aiming to kill the nodule, we're aiming to kill the symptoms. So the whole point of this is a symptomatic relief. There can be situations such as overactive nodules, which can be treated, and Farhan's touched on the idea of being used for micropapillary cancers or small cancers, which have not spread anywhere. And that's very much, there's something very recently that's come out in the literature. In fact, there's been a guideline recently that's come out as well. But at the moment, it's for benign nodules, and that's what it's licensed for in the UK. as I said, there's different types of energy levels that you can use. A high energy, which is a much quicker procedure, causes rapid soda, or there's low energies, which can be a bit more controlled and cause a slower procedure, but often less painful, better tolerated. There are different techniques to how to do it, and I'm going to play this video, which was, I think this is possibly the one that was on the BBC website when we performed this. You can see this is what we call the fluid motion technique, and I've zoomed in there to show how, whilst you're doing the ultrasound and forming on the neck, you can see the probe, that's that red and white structure in my hand, rotating around as we do it. So you do feel a continuous sense of movement with the fluid motion technique. There is also the ability to position the probe once, create a burn, then reposition it with a nodule, create another burn until you overlap and cover the entire thing. Or there's something called the moving shot technique, which is more common with radio frequency ablation, but is also used in microwave, where you can create essentially multiple lines of burns as you retract a nodule. Now, the benefit of microwave ablation is that it is very quick, and the studies suggest that it's less uncomfortable. Radio frequency ablation does take a little bit longer, but that's partially because it employs this moving shot technique. Whereas with what's more commonly used as a fluid motion technique, you cause this mechanical disruption alongside the heat disruption. And now, as I promised, I'll talk to you about the complications. So starting with the alcohol side of it. Now, this is a bit that nobody wants to hear, and in some ways, this is a bit like reading the back of a paracetamol packet. There are a number of things that can happen, and we like to warn people about the common and the severe. Those are really the ones that we want people to know about. And more often, these will be the severe that are talked about as opposed to the common. And I'll tell you which ones are which. So with alcohol injection, it's very rare to get any complications. The main one is alcohol leakage, and within that, you can get alcohol leakage on the skin or around the gland, or you can get alcohol leakage into the blood vessels and then absorption, which can actually cause alcohol intoxication. So it's why we advise people not to drive afterwards as well. If it leaks around the outside, the alcohol scars, so it causes scarring of whatever it touches. And that's one of the reasons why we go through the middle of the neck. So we have a bit of stability there. So it's less likely to leak. As you can see in hopefully in that picture, you can see there's an approach from a middle of the thyroid as opposed to from one side. If it leaks, it can also cause quite a severe pain, and it can scar the nerves around and damage those as well, including what we call the recurrent laryngeal nerve, which many of you would have heard of as the nerve that supplies the vocal cords, and that can cause temporary or permanent hoarse voice. With that's really about all there is of note from the alcohol ablation. Of course, there's a risk that the cyst may not be fully treated and you may need to treat again, but that's quite a small percentage and it's shown to be very effective. What you may get with the microwave thyroid ablation is slightly different, because fundamentally you're introducing a needle, much like the needle that you see in that picture. So there's a chance of mechanical injury, and because you've got the structures around, there's a chance of directly puncturing through. This includes the airway and the esophagus, but also things like the nerves or the blood vessels in the neck. Now, I know that's very dramatic to hear, but I can reassure you, as someone who's dealing with ultrasound on a regular basis, Farm will tell you as well, what's a millimeter on the screen is really quite a lot of movement, because you're magnifying what you're doing, you're watching every single step of your way. So the chances of that happening are quite rare. There is also the rare chance of inducing hypothyroidism. Now, we say this, but really and truly, you're treating far less of the thyroid than you do with a hemithyroidectomy. So actually, it's much lower. What is more specific to thyroid ablation is there's a chance the nodule can rupture, and more this is thought to be from late bleeding within a nodule. And because it's a thinned wall and because it's under pressure, then it can rupture and cause quite dramatic bruising over the front of the chest, or it may even compress the airway. With that, there's a risk of emergency thyroid removal, and that's with any minimally invasive procedure has a risk of becoming maximally invasive. What is more realistic as a small complication is a risk of a skin burn. Now, what's reassuring is these probes are very small, and I normally have a biro around to show you, but it's about the width of an inside of a biro, this probe. So the skin nick is no more than a centimeter. So even should a skin burn happen, it's a very small area. So just the other day, actually, I was seeing a patient, and the reason we were doing it for him was rather than a hemithyroidectomy was his worry about keloid scarring. So it's particularly important to think about how you approach these nodules as well when you do it. So the risk is all quite low, but it is something that I think, as with any procedure, it just needs to be an awareness of it being there. The small risk is, and Fran alluded to this with the follow-up period, is the risk of regrowth. The risk of regrowth is estimated somewhere between 1% and 2% of thyroid nodules, depending on how much you treat. You aim to treat about 70 to 90% of the nodule. You don't want to destroy it all because then you risk causing damage to surrounding structures. But that's why we keep under regular follow-up, and most importantly, symptomatic follow-up, because that's what's critical to us. In terms of what you feel, and I'll keep this brief because I appreciate probably running into people's dinner time as well. What you'll feel on the day will be that you'll have a sense of stretching your neck, because usually we like to extend people's neck to try and get to the nodules. There is always going to be a slight feeling of pressure with the application of the probe and the need to push the needle in, and that's the sort of equipment that you see on that trolley there. Local anesthetic, whatever the cause and whenever you give it, it stings, but we can put things in the local anesthetic to make it slightly more comfortable. Usually you find this is very well tolerated. With radiofrequency ablation, you tend to feel a popping sensation and you perhaps even hear a popping sensation. With microwave ablation, it can occur, but you tend to feel more of a diffuse warmth in the neck, and it can ascend up the jaw and to the neck, towards the head. Reassuringly, when you pause, the discomfort disappears immediately, and then you can restart. So there's an option to continually talk to the patient. And as said before, we don't really sedate for this. We try not to sedate, and I would say the majority of our patients don't actually need anything further than the local anesthetic and maybe some paracetamol. Although we do advise people to take a bit of ibuprofen the next day or the day after. We routinely perform ours on a Thursday, and I follow up people on the Friday morning. They generally report a bit of stiffness in the neck, if anything, and some mild swelling, perhaps even slightly more than the nodule was itself initially on the first day or so. And then it starts to go back to normal in terms of the stiffness. By the Saturday, almost invariably they're fine. So it's back to normal function with that. I then follow people up normally a week or two afterwards, and that's when they often are surprised I'm calling at that point, saying they feel fine. And certainly by the 3-month mark, everyone is very much reassured and sees a significant effect. We are treating some of the largest nodules in the literature, actually. And just as a brief run through, this is what we've seen so far over a year. A reduction in 56 mils nodules size to 9 mils, which is 84% reduction in size. That's an example of a treated nodule there. But you can see how the big reduction happens in the first 3 months, and then there's continual reduction afterwards. And people actually are seeing reduction even up to 2 years continually, but the volume of reduction decreases each setting. This is probably the thing that's most important, is we give all our patients a quality of life questionnaire at the start, at each interval, and at the 1-year follow-up, with the lowest score being 23 for the 23 questions, and the highest score being 115. Now, what's critical is no one's scoring 115, because these are symptoms that if someone's scoring really high marks, they would generally be going for surgery. But it's these people who are in the middle of the pack that are uncomfortable, but don't necessarily want to take that step. And you can see it reduces to essentially no symptoms by 12 months out. And you can see the type of symptoms improve significantly. So from neck pain, discomfort, to swallowing difficulties, or body image, mild cough, restlessness, and by 12 months, everything is entirely resolved. And these are just some examples, because it's always nice to show examples. Now, I think only the top patient on the right wearing the necklace was at 12 months afterwards, and she had a comparatively less visible nodule on the outside. The top patient on the left, I think that was 2 months, 3 months at the bottom, and 3 months in the bottom as well. And this is something that I think the numbers don't really give you a feeling of how patients do from this and how much it improves them. And I think it's I often ask for quotes from patients to tell me how they're actually getting on with their life. And this is a nice one. A patient who clearly has an Apple Watch, who's telling me that they couldn't go on their walking holidays because they felt very breathless. And actually, post ablation, their active energy is up, their number of calories, their walking speed is up. They went for a walking holiday in Corsica and Sardinia a week afterwards, and walking absolutely fine, keeping up with their friends. And that's the sort of good news story we want to hear, the sort of reason why we do this procedure. And I've also asked to be invited to Sardinia next time as well. So I just conclude by saying that the minimally invasive thyroid treatments are safe, effective, and well tolerated. And I hope, much like my daughter there, they make you feel like they're on top of the world afterwards. Thank you.
Thank you, Tim. That's great. So we will now move on to a patient story, really, with Jill Pearson, who had radiofrequency ablation, and I'm just going to do like a mini interview with her. So thank you, Jill, for attending here. So what type of thyroid nodule did you have?
So I believe it was described as a cystic nodule. I think classification is U2. Yeah. So in terms of I don't know if you wanted to explain that to the patients. I couldn't explain it what U2 means.
So U2 means it's a benign nodule.
Okay.
From U3 onwards, we worry more that it may not be benign.
Fine. Okay. In terms of size, it was 26 mil, and the radiologist described it as the size of a lemon. Yeah. So it was on the left-hand side of my neck here. Quite obvious. I mean, I would have some close family and friends that would say, oh, you know, are you having that seen too, because it's getting bigger. And I sort of was becoming more aware of it anyway over a period of years.
Was it diagnosed because you went to them saying I've got this lump, or was there what was
I actually went to the GP about 8 years ago because I noticed a bit of a swelling there. My mum in her 50s had an overactive thyroid, and although I wasn't getting symptoms at that time, I just wanted to get it checked out. And I had an ultrasound at that time, and they said, oh, it's just a cyst, don't worry about it, go away. If it's not bothering you, we won't touch it. And I said, that's fine. And I think I had the thyroid function test at the time, and they said, there's nothing wrong, just don't worry about it. And I didn't. And then a couple of years ago, I started to get symptoms, and then that's when I went back.
What symptoms did you have?
Quite a lot of compression on that side of my neck. It would cause me disturbed sleep, particularly if I was lying on my right, I suppose, as it was pushing down that way. And I would sort of wake quite suddenly. And I don't know if it was cutting off the airway, but it was certainly disturbing my sleep. Used to have quite a few coughing fits, particularly when I was eating. So I was very mindful that I should eat small pieces and be very careful when I was swallowing. But I would get these terrible coughing fits that were quite anxiety provoking. It was really, really scary at times. And then, of course, aesthetically, it was quite obvious. One thing that started just a few months actually before treatment was I started to get a pain radiating down my collarbone, which was a bit odd. I don't know if there was some nerve, something going on there, which touching something, but that started to become quite painful as well. So that's why I decided really to start going forward and looking for something that could help.
What treatments were you offered?
Initially surgery. So I was referred to an ENT consultant at the local hospital. I was offered surgery. I asked if there were any other options, but at that time, well, they said no, there was nothing they could offer me. I live in Wales, in North Wales, near Wrexham, and there's no other options other than surgery. I wasn't keen on surgery. I wanted to avoid it as much as possible. I'd had surgery about 12 months previous for something completely different. And because of a back problem, my recovery just took ages, and I got into quite painful back you know, so I wanted to just avoid it as much as possible. So the research started.
And so what happened? So you said, actually, I'm not keen on surgery. So how did you then
I said,
come to find other options?
I just said, leave me on the list, and left it at that. And I said, I'd like to maybe look at other options. So yeah, my fingers touched the keyboard, and I just literally found British Thyroid Association. I contacted them and asked them if they did know of any other options, and they were really helpful, gave me the different options and gave me some contacts in terms of where other procedures were available. And then I started reaching out. I thought I'd probably have to go down the private route, and was willing to do that to avoid surgery, really. And I did see a consultant in Birmingham with regards to ethanol ablation, but when he looked at it, he said he couldn't do it because it wasn't suitable, but he knew a man who could. So I was then put in touch with Newcastle. So I went to the Freeman Hospital in Newcastle. I then had to go back to my ENT consultant, and I think Farhan touched on it earlier. He talked about the independent patient funding, individual funding request, which is what I had to do. So that had to be done through the ENT consultant. Took some time, but it happened.
Okay. Yeah, and I think you will find, and Neil Sharma will come back to this, because with the trial we're rolling out, that this is already become more available in the UK, and will be sort of universal, we hope, after the rabbit trial. So what was the procedure like?
So in total, from sort of entering the treatment room to leaving the room, it took about 45 minutes. The staff were very reassuring. They obviously prepared me in terms of getting me ready, cleaning the area, local anaesthetic, tiny scratch, a little bit of a sting, and then felt very little after that. The weirdest thing, and I think Tim mentioned it, was this popping sensation. I don't know if anyone's ever made popcorn themselves. It was literally very similar to hearing that, and there was a strange sensation going on. Not painful, didn't bother me, didn't make me feel nauseous or anything like that. It just felt a little bit weird, and the noise was quite funny. I chatted to the staff all the way through the treatment. It was, and any time that I needed to stop, because I had this pain radiating down my collarbone occasionally when the radiologist maybe went to a certain area, and I would just put my hand up and we'd stop, have a little breather, and then start again. And as I say, 45 minutes later, I was out of the room and having my cup of tea and a biscuit, and sort of waited for about an hour or so, and off I went.
Excellent. And how quick was the recovery?
So because we travelled to Newcastle from Wales, we stayed in a hotel. So that afternoon, I just rested, had some couple of paracetamol and rested. It was a little bit sore to the touch, I've just sort of, you have to have a little touch, don't you? So I just sort of touched it, just a little bit tender. I didn't notice any additional swelling other than the nodule itself. But by the next day, I'd say it wasn't as sore at all. And then we travelled back. We drove, I don't know, for about 5 hours, and I was fine. And then actually by the next day, so about 48 hours, I could touch it and it wasn't even sore. It was just, recovery was really quick.
Amazing. And how are you feeling now?
Great. So instead of a lemon, I now have a grape, apparently. So we're at 8 mils. That was at 6 months. That was in February. So I had it done on the 3rd of August, 24. And in February, it was at 8 mil. Here, I mean, I could literally cup almost to the nodule, and I'll give you a close-up. It's hardly anything there. So there's nothing.
Amazing.
I can feel a little, and just feel it a little bit. There is something, there is probably maybe a raisin there now. It's not even a grape now, but yeah, it's fine. So everything that I was experiencing before, I'm sleeping better, which means my energy levels are so much better. No coughing. I haven't had any coughing fit. A couple of weeks after, I still had that, but within about a month, that just went. The pain going down my collarbone was gone within 24 hours. That had just gone, which was really odd. So yeah, it's brilliant. I couldn't have asked for a better result, really.
Great to hear. And so the final minute, what would you say to anyone who is considering RFA for a benign non-toxic thyroid nodule?
Well, yes. I mean, I'm in a great place. I didn't have any complications. Think about the risks. Think about surgery. If that's not for you, then look at the options, the different options. And, you know, if your ENT consultant says we can only offer you surgery, then look at the options elsewhere, because it can be done. Recovery was so quick, you know, compared to what recovery in surgery would have been. So yeah, just look at the options. Do it.
Thank you. Thank you very much, Jill. That was
you're welcome.
Very enlightening, I'm sure, for everyone on the call. So finally now, because I am conscious that we would also like to have some questions, Neil Sharma is, so he's a consultant ENT surgeon at the Queen Elizabeth Hospital in Birmingham, and he's going to talk about the rabbit trial. Neil.
Thank you, Christine. And thanks, Gillian, for talking us through that. I think that's really useful to hear the sort of lived patient experience of this after hearing Farhan and Tim talk about the practical side of things. So I'm just going to talk just for a couple of minutes about a trial that follows on from what you've been hearing so far. And this was conceived a number of years ago when NICE approved initially radiofrequency ablation. As Tim said, it's now moved on to microwave and thermal ablation generally. And this is a rabbit trial that's looking to compare radiofrequency ablation of thyroid nodules with surgery. It's funded by the NIHR. It's rolled out across the country, and I'll talk a bit more about how you as patients and any professionals on the call can get involved. So this is the strap line, the rather catchy strap line that we submit for the NIHR. Essentially what it boils down to is, how does RFA compare with surgery? I won't go too much into the background. Many of you will know all of this, and we've heard Farhan and Tim talk about the background of thyroid nodules. But the key thing is the bottom one, really, in that much as we know from lots of reports that RFA and now microwave ablation seem to have good, if not better, results than surgery, we don't have any level 1, which is really high quality evidence showing that from a patient outcome experience when they're compared head to head, or a cost effectiveness aspect as well. And it's really those are the things that hospitals are looking at when they want to try and fund these techniques. And so we wanted to provide that evidence that can be used both nationally and internationally, so that we can get RFA really rolled out across the country. And you might say, well, why do we need to do a trial if we know that it works? And we've heard already that there's lots of studies just looking at case series of radiofrequency ablation and microwave to see if it works. But as I said, it's to allow us to get that high quality evidence to show that it's effective, to show that it's safe. And more importantly, Farhan on his slide showed how more hospitals now in the UK are able to offer thyroid RFA, but that is still the minority of hospitals. And a lot of centres run into trouble with resourcing. We're all strapped for cash at the moment in the NHS. If you go to your managers and say, I'd like training, I'd like to set up this new service, often they'll just say no. The trial will allow centres that aren't doing it to get trained up, to get the equipment in site, to get to reduce price, so they can start offering RFA, and then we can use the data that's generated to allow business cases to be written, and ultimately to allow no postcode lottery of who can get RFA, and hopefully for patients like you, Gillian, won't have to travel many hours just to get this treatment. So very broadly, who's it for? Well, it's for adults. We're not using it for children, and it's benign thyroid nodules that aren't overactive. We heard how these techniques are really good for overactive thyroid nodules, but in the trial, we're just looking at normally functioning thyroid nodules, and ones that are causing problems. And problems don't just have to be compressive symptoms. It can count as cosmetic symptoms as well. And if you're taking part, what would you have to do? What would you expect? Well, if you haven't already had a needle biopsy done to show that it's definitely benign, even if it looks benign on ultrasound, you will need to have another one done. And really importantly, if you're taking part, you would have to be willing to be randomized to either have surgery or radiofrequency ablation. And your team will talk to you about this. What we really want to encourage patients to do is if they're coming to see their consultant, whether it's a surgeon or an endocrinologist, and that centre's taking part in the rabbit trial, to have a good open discussion with your clinician to find out what it would involve, and then hopefully to go ahead with the trial. There are questionnaires that you'd have to do before the treatment and after the treatment for a number of years afterwards. And that's really important so we know what the longer term effects are of radiofrequency ablation and surgery on your quality of life. And you'd have to be willing to come back for follow-up appointments and scans, but that would be fairly standard anyway if you were having radiofrequency ablation and follow-up appointments for surgery. And how will it help us? Well, the answers to these questionnaires will really help us understand the impact that RFA has on quality of life, and directly comparing that to surgery in a really well set up trial setting. And we also want to look at what complications occur. We know from lots of studies what the complication risk is from surgery, but no studies have looked directly head to head at a similar group of patients having either RFA or surgery. And finally, and for me as a clinician, this is sort of the least important aspect, is the cost effectiveness. But again, when we're going to our hospitals saying we want to set up RFA, we want to be able to show that it is cost effective and we can help reduce that cost burden on the NHS. So how would you get involved? Well, if you've got a benign thyroid nodule and you've seen a team, find out if that hospital is taking part in the rabbit trial and ask if you could be eligible for it. You can see these are all the centres that are getting set up or have indicated they want to take part. And we're working on training many of these sites that don't do RFA to be able to get set up in the trial. So talk to your clinicians, talk to us if you need to, and we can really help you get set up. I think that's everything, Christine.
Thank you, Neil. Absolutely brilliant. Could I ask all speakers to put their video on? There's quite a few questions in the chat. I hope everyone is willing to stay on a little bit longer. We were a little bit late starting, but there's at least 12 questions here. And so the first one, maybe I'll go to Farhan. Is it worth having your hot nodule treated if it doesn't cause symptoms?
The short answer is yes. Because I mentioned that there is a cardiovascular risk and a risk on bone density in the long term. As to whether ablation is the right treatment, there are quite reasonably well-defined criteria as to which nodules might be amenable to treatment. So actually, the nodules that you treat and get a sustained effect with are very small nodules, so around the 10 to 15 mil mark. So these are not big nodules, and that's one of the criteria we look at if we're going to offer treatment for hot nodules.
Thank you. Second question, and I'll let Neil ask some questions, is maybe I'll go to Tim, what's the maximum size of a nodule for RFA treatment?
So I'll comment from the microwave side. Generally, RF, it's a longer procedure, so it can be quite time consuming for very large nodules. For microwave, the largest I've treated is 11 centimeters as a single nodule in a single sitting. It's probably close to the upper limit, but there isn't an absolute upper limit. What we do restrict on is the idea of treating one side at a time. So we would never treat bilateral in a sitting because of the risk of central airway compression.
Thank you. And Farhan for RFA?
Again, I'd agree with Tim. There's no upper limit to what you can treat, but you need to be really careful when you're treating very large nodules, because there is a high risk of pore shrinkage, repeat treatment, and patients need to understand that. And I certainly wouldn't treat bilateral nodules, as Tim wouldn't either. I'd go for one side. If it's a dominant nodule, even producing a 50% shrinkage of a large nodule might cause significant improvement in symptoms.
Thank you.
Okay, so next question, I guess this relates to especially patients that are thinking about radioiodine ablation for a toxic thyroid nodule. If someone wants to conceive after ablation, how long should you leave it before trying to conceive? Obviously, there are guidelines in place for patients having radioiodine. Tim, do you have any guidance for this?
So for thermal ablation techniques, in truth, there's not really a time limit because once you've finished the procedure, you've left. That's it, really. There's not a time limit. What I would say is that we do treat pregnancy as a contraindication to doing microwave ablation or thermal ablation at all, not because it technically affects the baby, but more just because there's no necessity to have it at that time. It's better to either to wait and make sure that the body doesn't go under undue stress unnecessarily. But there's not a time limit to waiting for conceive.
And Farhan, I think that's the same for RFA, isn't it?
It is, but I would add the caveat that if you start a treatment, you'd want to make sure that you've got a sustained euthyroid state, because if you had to go in and treat again, you want to make sure that you can do that treatment and then maybe get on with a planned pregnancy.
I would also add, sorry, I forgot to mention that because thyroid nodules can increase in pregnancy as well. It's something to bear in mind if you're at that stage of considering before conceiving.
Yeah, thank you both. How many times can you go through the treatment? Farhan, you talked about single sittings for this. What?
Yeah, so if we are going to offer a second treatment, we don't rush into it. So even if, let's say, we get a very modest shrinkage at 3 months, I would always encourage patients, even if they've still got significant symptoms, to wait at least a year before they consider retreatment, because we're going to see significant, if not slightly more modest shrinkage, even out to a year. And I think Tim's experienced that as well. So we don't rush back into it.
Okay. Tim, agreed?
Yeah.
This is for both of you. Which is better? So you fight it out.
Go on, Tim.
My story is I had an option to choose. I was fortunate enough to be in that position, and it was as an interventionist, most of my other work had converted from radio frequency to microwave anyway. The type of microwave I use for me sits between what's conventional microwave ablation as a more high powered technique, and radio frequency ablation, which is a more sort of slower controlled technique. So the low power microwave for me is the preferable option. The literature suggests it's less uncomfortable for patients and that it's quicker. We've so far our results, you see I've quoted there, said 85% volume reduction at a year on average, which is with 56 mil nodules. That's actually probably the best results in the literature so far. And well, soon to be released in the literature. So for me, I prefer microwave, but radio frequency certainly has its advantages in terms of particular precision and points you need to do. So it may well be that when it comes to particular types of nodules, they very much coexist as opposed to being one against another.
Yeah, and all I would add to that is that, I mean, there's no evidence or good quality evidence to suggest that one is superior to the other. They work broadly on the same principle of delivering energy and heat and shrinking the nodule. Often, in terms of what a doctor adopts in terms of the treatment, depends on their personal preference and availability. So it's more about how you deliver the treatment, how thorough you are, taking the time and the training. I don't think we can say at this time that one is better than the other.
Brilliant. So the next question is from someone who has 2 smaller benign nodules, but they're causing mild hyperthyroidism. Been offered radioactive iodine treatment, but doesn't want to become hypothyroid. So this is 2 small benign. I presume at least one of them is toxic. And the question is, can they have ablation without causing hypothyroidism?
I think the answer is yes, they can. The key is to identifying which nodule is causing the overactivity. So the first thing is having a thyroid uptake scan and correlating a nodule with overactivity, which you can then target, and just making sure that it's a small enough nodule that you feel that you can get a normal thyroid state.
Thank you.
cystic group.
Okay, I'm going to group a couple of questions because I'm conscious that we want to try and get through as many as possible. So in terms of cystic nodules, I guess for both of you, this is more around ethanol ablation. So our two sort of questions. In a nodule that's been aspirated twice and subsequently refilled, would microwave or ethanol ablation or microwave radiofrequency or ethanol ablation be better if they wish to avoid surgery? And on the other one, does it have to be aspirated to dryness before going ahead with ablation? So Farhan, thoughts on cystic nodules? I think we know where you're going to go with this.
Yeah, no. So I would, if it was less than 20% solid, I would always try alcohol ablation first. So the first thing to try is just to aspirate it. Some nodules get smaller. I'd then try alcohol ablation maybe a couple of times, and then if that didn't work, I would offer RFA. And what I tend to do is on the day I'd aspirate all the fluid. I then press just to try and prevent the nodule from filling with blood, and then I would go ahead and ablate.
Okay, thank you. Tim, does that sound similar?
Yeah, similar effectively.
Yeah.
Dominant cystic alcohol is by far proven to be the best thing.
Yeah. And
we often combine it as well with some nodules that are a reasonable proportion cystic but have a solid component. So we have done alcohol followed by microwave as well.
Excellent, thank you. And steroid cover. Someone's put in the comments that some countries recommend a course of steroids after ablation. Do either of you two do this routinely?
No.
I don't routinely, no.
No.
No. And don't
I wouldn't say it's absolutely standard practice as yet, but it's just based on the inflammatory reaction.
Okay. I'm going to jump in for one saying, can RFA be used for a Thy-3 nodule replacement of lobectomy? Not yet. I think that's fair to say, both of you. I think when there is a suspicion of malignancy, we are still recommending lobectomy. But you know, there are other things that we're got in the pipeline to look at in terms of how we can better differentiate these certainly Thy-3A nodules, as they do in the States with genetic testing of the nodule. Christine, have you got another one?
So what about a multinodular goiter? I think we've already touched on it slightly, but so someone who has multiple nodules, would you use microwave ablation or RFA, I presume?
I mean, I tend not to offer RFA for multinodular goiters. In my experience, they haven't done well, but Tim may have different experiences.
We've had a couple that we've done where it's more localizable, the symptoms. So someone is saying it's this bit of my neck that bothers me putting on a shirt or so on, as opposed to for a general reduction in size. So we have used it for debulking, so to speak, where we haven't entirely respected nodule borders. But I would not generally offer it because I think it's important to bear in mind surgery still, it's still there. This is alternative to surgery as opposed to a replacement for surgery. So it's for particular cohorts.
Okay, and then somebody's asking about, you know, how long has it been in use, and therefore do we have really long-term follow-up data? Or long-term?
Yes, is my short answer for that.
Yeah.
There's lots of long-term follow-up data. Most recently, I say most recently, even that was a couple of years ago. The point about talking about small cancers, there's a study with 10-year follow-up data from that alone. And that was after the initial period of treating the benign nodules and establishing the safety of that. So this has been going for a very long time, both microwave and radiofrequency, and ethanol has been around even preceding that as well.
Neil, this one's to you. Can microwave ablation be used in rabbit?
So Sid, thank you for asking. No, unfortunately. When we were first setting up the rabbit trial, it was RFA that was in use, so everything's gone forward with RFA for the trial. We understand, you know, Tim's obviously well set up with microwave, but the majority of other centres are using RFA, so it's RFA that we're going with. You know, subsequent trials we're going to be looking at cancers, probably will incorporate thermal ablation more generally, but for rabbit it's just RFA. And then this is one that's we've discussed, Tim. I've had a hemithyroidectomy to remove a cancerous nodule. On the other side, I have a 5 centimeter nodule that is overactive and has been diagnosed as benign by FNA. Would that be considered for microwave? So a toxic nodule on one side and a malignancy on the other side that has been treated and doesn't require any further treatment other than observation.
So I think the critical thing is the malignancy doesn't require any further treatment there, because if it does, then the route is quite clear, really, isn't it? That surgical is the best way forward. The 5 centimeter overactive nodule makes it a little bit more difficult because, as Farhan mentioned, the smaller the nodule, the hyperactive nodule, the better you can get the encompassing treatment. Because unfortunately, what you can't say is if I treat 80% of the nodule, I'll have an 80% reduction in the thyroid function. It's not quite so precise as that. So I think it can be approached and it can be treated, but it's with an expectation that you may not achieve the desired results. What it's much better for generally is for the small nodules that are overactive and the larger nodules that are symptomatic from a mass effect point of view.
Yeah.
So there's a question on flying after RFA or embolization. Are there any restrictions on flying?
I mean, not other than being sensible. So I wouldn't go immediately away on a flight, but I'd give at least a couple of weeks, before considering going away on a holiday, and actually, maybe slightly longer just to make sure everything is okay. That's me being cautious. But normal activities are resumed within a day or two. And the only thing I do restrict is being too excessive in the gym until they see me again at 3 months. And my thought is putting pressure on that area may potentially increase the risk of nodule rupture, but I've got no good evidence for that. That's just me.
Yeah.
I think
Okay,
one last
so-
one, Neil, and then we'll have to stop because we're 10 minutes over.
Okay, I'll just give quickly with this one. I can answer this one quickly. Are there ENT units with thyroid surgeons performing these ablations, or is it solely with radiology? With my BATS hat on, I'll say ENT or endocrine surgery units. So in the UK, the vast majority of thyroid diagnostic ultrasound is done by radiologists. Overseas, a lot more is done by endocrinology and surgery. And I think the main criteria is you have to be a really competent thyroid radiologist and comfortable carrying out FNA. So this isn't something for a jobbing surgeon that fancies a go to start doing. Our colleague George McCoulis in Lister spent a long time with his radiologist carrying out thyroid ultrasound and FNA until he felt he was appropriately trained, and he is carrying them out, but with the radiologist. I think Farhan and Tim, it's still majority radiology carried out in this country.
Yeah, it's a mixture of head and neck radiologists and interventional radiologists. So people that are familiar with ultrasound guided techniques.
Okay,
Yeah.
I think we're 10 minutes over. There are still a few questions in the chat. I think sometimes the BTF offer the possibility that those are answered, and we might be turning to Farhan and Tim to answer some of those. But I'll hand over to Julia now.
Hi, everybody. Thank you very much. Am I still? There we are. Thank you very much, everybody. Thank you to our speakers, Tim and Farhan, and also to Christine and Neil as chairs. And a special thank you for Gillian. Thanks very much for sharing your story, which brought all the kind of technical details to life. It was really, really invaluable. This is really exciting treatments that are going to become available for patients throughout the UK over the next few years, and it's really really grateful that we've had the chance to learn so much about it. I think this resource, the recording, will be really useful for lots of people. Just a reminder, this webinar will be recorded, so check on our website in the next few days and you'll find it. There'll be a feedback form that comes out to you all after the meeting, so we're always happy to get any feedback and suggestions from you. As Christine said, if any of you've got any further questions, please send them into BTF and we'll do our best to get them answered by one of the experts. If you'd like to get more information about the rabbit trial, please have a look on our website. When it's up and running, there will be a dedicated area of our website showing the areas where it's available and how to find out how to to be referred into it, if that's to find out if you're eligible. But in the meantime, on the front page of our website, you can find an article that gives you an up-to-date interview with Neil about the rabbit trial to help you learn more. If you'd like to support BTF in any way, please feel free to donate. This will enable us to continue to offer events like this free of charge. There's a QR code on the screen that you can follow to make the donation. And also you can go to our website and you can join the BTF as well, if you'd like to do that. And finally, if you'd like to vote for BTF to win £5,000 for the Benefact Group Health and Wellbeing draw on the 4th of May, we'd be very grateful if you'd like to vote for us. It will just take a few moments of your time. Again, follow the QR code